Hi, everybody. Thank you for joining us in today's interview with Stefan Hartman. Stefan is a physician associate who I work with very closely on a regular basis. And I love his approach that is very unique and in the minority because he does also believe in an animal-based approach, ancestral approach, hormone optimization. And because of that, we're going to talk today about male hormone optimization. How are you, Stefan?
Excellent.
Thank you for joining me today. So, are you ready? You're gonna take the lead on this one.
Yes, I have a good lecture for you all today on male hormone optimization. And let me screen share if you'd allow that. And
Yeah.
I'll pull up my screen here and share the
Okay. I'm
presentation.
allowing it on my end.
Good. So today's lecture, it's going to be some cursory literature review, but as we'll see here, the literature primarily identifies disease populations. So we're going to go through a lot of anecdotes and case studies that I've been doing here at Iron Direct Primary Care with hormone optimization, both natural and pharmaceutical approach. So if you look at the literature, there's no agreement on what is a normal reference range, what is testosterone deficiency, nor what is hormone optimization. You can't find it. I spent hours trying to figure it out. Okay. So this is what I see on a day-to-day basis. Average testosterone levels age 30 to 40 in males. So free testosterone, maybe it's in the red on the reference range with LabCorp. Typically, I'm seeing a total testosterone between 300, 400, typically 500. That would be impressive. Free testosterone is pretty typically low. My brother and I were kind of exceptions to this rule. We have quite high testosterone levels. So we range typically in the thousands of the total and the free testosterone between 16 and 20. So maybe we're genetic outliers for this, but I rarely see something like this in my lab work. So we asked the question, what is optimal male testosterone levels? Can the literature provide any indication, right? Because the lab reference range seems to be way too wide, right? So what I do is we ask questions. We try to identify hypogonadism or low testosterone in the male with the questions. We ask, do you have poor sleep? Do you have low motivation? Do you have poor recovery? Maybe they're having recurrent injuries. You know, they're having more rotator cuff tears. Maybe their ligaments, tendons are weaker. This is a sign also of low anabolic factors. There's lesser known reasons why you would want optimal testosterone levels, which we're going to cover here in this lecture. These include low testosterone associated with increased cardiac disease, increased all-cause mortality, and actually increased cancer rates, kind of contrary to popular belief, which we'll look at here. Most of the literature is done on bone mineral density. It is well known that you will have weaker bones with low testosterone as you age. And so treatment and optimization of testosterone is well supported in the literature to prevent osteoporosis and osteopenia in the aging male. So here's more. You can find extensive research with this association of decreased bone mineral density and lower testosterone levels. Another thing that I want to talk about, because I work with optimization in athletes, is overtraining. And you can crush your testosterone with overtraining. And this is described in the literature as exercise hypogonadal male condition. So this brings up the debate. So you have athletes that overtrain because they're competing at the highest level and they have low testosterone. So even athletes do not give us an indicator of what is optimal testosterone levels because they can overtrain and crush their testosterone. They're still performing just fine, but maybe they have a total testosterone of 400. Does this mean they need hormone optimization and treatment? Well, if they're competing in Olympics and so forth, this is banned by the World Anti-Doping Commission, right? They're not allowed to do this.
Right.
And to,
What
go ahead.
What constitutes as overtraining? It's so hard to delineate when somebody has entered. And I think most people think they're overtraining if they're just training 1, 2, 3 hours a day. Um,
Yeah.
and I think it takes a lot more than that. Would you agree?
Yes. I would say most people aren't hitting overtraining, like 98% of the population we're talking about.
Yeah.
But
Yeah.
I sometimes see these outliers who come to me, and I see these outliers in the bodybuilders. So this is the example of someone who's using extraordinary. Wait, no, this isn't it.
Mhm.
Is it? Oh yeah, this is it. Okay, so this is someone using extraordinary exogenous testosterone. Okay, so bodybuilders, they train twice a day. They train probably 6 days a week. Maybe they'll give themselves a rest day. This is overtraining. So they will crush their testosterone down to super low levels. They'll crush their growth hormone down to super low levels. We know this from the Liver King's anecdote. He had, I guess, depression or some issue, and this drove him to overtrain twice a day, super intense workouts, and he crushed his hormones. So he sought out replacement therapy, but it was a little bit more than that, of course. This is what these high-level athletes will do. So the testosterone, it enables them to train at this level. So they can have poor sleep, they can be overtraining, and it doesn't matter. They'll always have a high testosterone level. And even at a replacement dose, so we're talking even at 200 milligrams a week of testosterone therapy, you're at super physiologic levels like that, right? So that's what a lot of people understand when they're on testosterone replacement therapy. Is you can have poor sleep, you can have a shit diet. If you're on testosterone therapy, you're going to have a consistently high level. So you're already super physiologic by replacement therapy. And then we talk about the athlete who's abusing steroids, right? So I don't prescribe these levels, but he's getting these on the black market, and he uses these to get these super physiologic levels. So we'll see total testosterone in the 2000s, right? We'll see it just indicating greater than 50 on the free, right? The lab can't even measure higher than this.
Oh.
The dihydrotestosterone is 159. This is extraordinarily high. Okay, his IGF-1 is super high from using HGH. 370 is pretty much impossible to achieve naturally.
Okay. And
His
vitamin D is high. I was so rare for me to find that.
So vitamin D is a steroid. Okay, so of
True.
course you would want to use vitamin D as a supplement because it's another steroid hormone. So he's using vitamin D, of course.
Oh, wow. Okay.
And his LH and FSH are expectedly suppressed to nothing. He
Right.
cannot produce his own at these levels. So these are stimulating hormones for testosterone. We can see his thyroid's pretty well optimized too. And he's not even taking the thyroid hormones. I think the way he's doing this, and we're going to cover this, I think, on the next slide, is growth hormone. Growth hormone actually will suppress the reverse T3 and will improve the conversion of T4 to T3. So I see this some in the literature, which maybe I'll bring this up here somewhere. The sex hormone binding globulin, this will suppress free testosterone. And we see this in some disease populations. I see this routinely in my diabetic and overweight patients. They'll have high sex hormone binding globulin, which will suppress their free testosterone to really low levels. We're talking like 5 and 3, super low levels.
Yeah.
So it's associated with a lot of chronic disease states, this
Yeah.
high sex hormone binding globulin.
Right. And from its name, sex hormone binding globulin, or SHBG, is just a protein that's going to bind to your hormones and prevent them from actually working. It's like suppressing their function by just neutralizing them. Right?
Yes.
Yeah.
Let's talk about a couple case studies here. So this is a cool one. This is a patient who went on a raw milk fast, and it lowered his LDL and his testosterone. So you can see raw milk fasts in the old literature in the 1900s when physicians would prescribe a raw milk diet to treat all sorts of conditions. So this patient, he didn't really have much of medical problems other than maybe high LDL particle numbers. And so he went on the raw milk fast for 5 days to see what would happen. What we see here is kind of interesting. So yes, his LDL particles dropped, pretty cool. His triglycerides dropped a little bit. His HDL worsened.
Mm-hmm.
But his LPIR score was insulin resistance score, which is a measure of the C peptide and the fasting insulin. It worsened. So he became more insulin resistant, which we might expect because raw milk, it's a lot of sugar. And if you're just drinking sugar over 5 days, we would maybe expect that.
Right. And it has a high insulin index, right? It in and of itself, milk is going to increase insulin production and IGF-1 levels and all those things. So it's as if you're eating carbs in a way.
It is. And IGF-1, yes, you're correct about that. It will increase.
Mm-hmm.
Is ApoB lipoprotein, it also improved, right? And we say indicators that ApoB lipoprotein may be a good indicator of cardiovascular risk. I don't know how true that is, but it did reduce on this. We see testosterone, though, dropping. He wasn't too happy to see this. It went in the wrong direction for him, right?
Interesting.
So
Yeah.
he wasn't happy about that.
Okay.
So this here is signs and symptoms suggestive of testosterone deficiency. So this is what I base a lot of my diagnostic criteria off of, because these levels, they can fluctuate with a bad night's sleep. They can fluctuate with, raw milk fast, all sorts of things. So you ask the patients how they're feeling, right? If they're having signs and symptoms of low testosterone, you make the diagnosis, right? The biomarkers are okay. They're a decent indicator, right? But these can change through a lot of different reasons, as we're going to show here. Let's talk about a one here. So we managed to get this guy from a total or a free of 2.6 to 14.8 in 2 months naturally with no hormone supplementation. Well, we're talking maybe about one we did.
Is this a different guy than
this is a different guy, different case. Okay, so he came to me, kind of held LDL particles, decent insulin resistance score, so not too much change, at least in regards to the LDL particles.
So triglycerides are great.
Yeah, his triglycerides were pretty good.
Yeah.
So this guy, he said he was eating a pretty good animal-based diet, right? He had watched your videos, he watched Carnivore MD, and so he did the carnivore diet. He thought he was doing great. However, he was drinking 6 cartons of coconut water daily. And I said, hey, buddy, grab this from your countertop. Let's see what the sugar levels are. There's a lot of sugar in this. We calculated he was consuming 140 grams of sugar a day. So even though he was doing carnivore diet, look at this. His glucose was 115. He was a diabetic. He was only age 30.
Fasted? That's crazy.
Yeah, not good.
Wow.
So this is kind of a wake-up call for him. He had a high reverse T3.
Yeah.
So this was suppressing his conversion of T4 to T3.
Yeah.
So maybe
let me pause you here for a second, since we're talking about fasted glucose. His is 115 milligrams per deciliter, which is insanely high. I normally have my fasted blood sugars literally like 72. If it might go to 82. But like that's the range throughout the whole day, even after eating, steak, eggs, cheese, bacon, things like that. On a strict carnivore diet, like it's so level. What would and I normally will tell my students, and when I'm recommending what is the best fasted blood sugar level is, I normally will say that it's ideally best to have it below 86 milligrams per deciliter. Would you agree with that recommendation?
That'd be fantastic if you can achieve that. But I don't always see that in people who eat carnivore or these sort of diets. Do you have any explanation? I've heard some reasons why this might be.
Yeah, I've heard and I've read like blog posts from health experts when they're talking about fasted blood sugars, and they'll always put a caveat that some people on a carnivore diet might actually have a higher fasted blood sugar, even like in the hundreds, like 100 or so, and we shouldn't be panicking as long as this is within the context of a zero carb diet. It seems like that's not a pathological condition or situation. I don't understand why exactly that happens, to be honest.
This guy, he was not doing zero carb. He was consuming inadvertently too much sugar.
Yeah.
So let's look at what else we had going on here. We had his liver function didn't look too bad. Well, maybe it was a little bit high. So 31 of an AST. and a 28 for an ALT. So I prefer maybe in the teens, AST and ALT. That'd be more optimal for me. Higher indicates maybe a little bit of fat on the liver.
Gotcha.
So we gave this guy a hormone. We did give him CJC ipamorelin. And as I alluded to earlier, these growth hormones, they can actually improve the T3 level. So through a couple mechanisms.
What is it
so
exactly that you gave him? I didn't catch the actual name.
Yeah, so we gave him CJC ipamorelin, which is a growth hormone secreting peptide, right? It stimulates the pituitary to release growth hormone. So different than the bodybuilder that we looked at, he was using exogenous growth hormones. He was using ortitropin or omnitrope or something like that. We're using these that help the pituitary release it again. Because I have it around here somewhere. This guy had a decently low IGF-1.
Okay.
And I think this is the reason why also his T3 improved and his reverse T3 also decreased. We also got him on some selenium and iodine, which can help as well.
Okay.
Where is it? Oh, here, yeah, here it is. So here's his testosterone levels, this guy. We repeated these labs. August was the first one, and then we repeated them in December. So at the time of drawing, I think he had COVID actually, and he was kind of sick. That's what he came to me. He actually had an elevated D-dimer, which is around here somewhere. But yeah, he was drinking orange.
You had him tested for D-dimer?
Oh yeah, I did. I knew he had the type. He drinks a lot of coconut juice and the orange juice, 140 grams of sugar a day. Where's his? So let's just look at this page first, then we'll move on to the next one. Low testosterone, total 140, free testosterone 2.6. And so we managed to reverse this completely in 2 months, just with changing up the diet and giving him a couple supplements.
That's amazing. So it went in just 2 months, his testosterone went from 147.7 to 454.6. That's incredible.
Yeah, we gave him some DHEA. As we can see, we increased that a lot with 25 milligram of DHEA supplement every day. We did some glutathione for him, some NAD, and some vitamin D. Again, vitamin D is a steroid hormone that will help support your hormones. Yeah. We gave him some thistle that can help with the liver, detoxing the liver. We also gave him ivermectin and nepronol. So because I suspected he had COVID at the time because of the high D-dimer and his symptoms. So nepronol is a fibrinolytic. It helps break down clot formation. We ivermectin, 42 milligrams, that's the treatment dose. And he did pretty well. Within a couple of days, he started feeling better.
How can you elaborate a little bit more on the D-dimer without in a very like you know what I mean, like a conservative way, so that they don't
flag my video? So D-dimer, this is traditionally used in the emergency room as a screening for pulmonary embolism. It can be elevated for a lot of reasons, trauma, cancers. But if you're having more clot release, it measures that. And I have found that this is always high in patients who are suffering with COVID, long COVID, etc. And so I do make this a point of measuring in these type of cases.
And how do you, and you drop it down using the FLCCC protocol?
Yeah, we use the FLCCC protocol to treat this guy.
Yeah. And
when you're in a high inflammatory state, as he had been, maybe that high sugar was contributing to some of this as well. It's kind of unclear why a D-dimer might elevate, but I think at least in his case, it was the COVID. But he didn't have signs of a pulmonary embolism. Like, I wasn't worried about that. I was using it as a marker to measure his illness, his sickness, and track some markers.
And it was high.
It was high. Yeah. And so we can see his fasting insulin was super high too on this high sugar carnivore diet that he was doing. Okay. It was, I would call it like a 30 carnivore, 18 fasting insulin. That's not good. Okay.
No. So this is here a little bit of a cautionary tale, because I know a lot of people now are loving the whole animal-based plus high sugar, the fructose from the honey
Yeah.
and from the fruits.
Yeah,
You know,
yeah.
that's why I
He was
wouldn't
doing all that.
recommend.
He watched the carnivore MD who's in Costa Rica, and he's eating all this sugar and stuff, and he thought
Yeah,
he could do the same thing. This guy's an engineer. He sits at his desk 8 hours a day, 5 days a
right.
week.
You're not working out as much as Dr. Saladino is, you know, and maybe even your metabolism previously, your previous history with that is different than somebody who's always been healthy, never had a sugar addiction or carbohydrate addiction issue, you know, so two different things.
Yeah. Now we did enhance this guy. One way we enhanced him was with the CJC ipamorelin, and he made extreme progress within these 2 months. And one of my friends, he saw him at the gym, and he told me like, "What did you do to this guy? He made the progress that he should have made in a year within 2 months." And we attribute this some to the CJC ipamorelin. His face leaned out, his
The
muscles
growth
grew,
hormone secretion improved because
it
of that
improved.
peptide. Mm-hmm.
Yeah, and maybe his inflammation reduced as well. It's very anti-inflammatory. Plus, you remove the sugar from the diet, your face shrinks up. It's not so swollen anymore.
And I see the CRP was at 2 and then it went to less than 1.
Mhm.
Do you also sometimes measure HSCRP, high sensitivity CRP? And do you think there's a big difference between the two?
There is, yeah. There's also a price difference, which is why I don't measure the HSCRP.
Yeah. That's the thing with, you know, insurance companies, they really make you work hard for that to ask for an
Well, these are
HSCRP.
all non-insurance labs, so I can get all these labs done very affordably.
Oh,
$140, $160, you can get this whole panel done.
oh, fantastic. And
Yeah,
yeah, I'll make sure obviously I'll link all of your information in the description box below so that people, if they're interested in this and they want to get all of this data for
yeah.
themselves, it's very affordable actually. You
Do
can
not
take this.
attempt to bill insurance. You'll get a bill in the mail for $2,500.
How can you get it for such a cheap price when insurance companies are like, what is going on?
Ah, you must allow me some secrets.
Okay.
So for this again, we'll go back to some of the boring data. They're looking at disease populations. So this is an India study. Lack of optimal testosterone ranges. They're looking at frailty in these populations. Yeah, very frail, low testosterone. They go hand in hand. Okay.
Wow. Okay.
Prevalence of testosterone deficiency among aging men with and without comorbidities. So you can see then a very frequent association of low testosterone with more morbidities, comorbidities, diabetes, high blood pressure, hyperlipidemia, frailty, COPD. All these things go hand in hand.
Mm-hmm.
Let's address some of the elephants in the room. I always get patients, they've watched the New York Times or CNN, and they say testosterone causes heart attacks, right? No, that's not the case. Actually, the opposite is true. And if we just look at some of these inflammatory cytokines, right? The IL-6, the NF-kappa B, we know that these are higher in COVID, right? But these are
Uh-huh.
also higher in low testosterone populations as well. So they'll have more of an inflammatory response to the COVID-19,
Yeah,
which,
so all of those molecules that we have in front of us here, you've got the tumor necrosis factor alpha, interferon, is that interferon gamma?
yeah,
Yeah, nuclear factor kappa B, TLRAP. Is that adiponectin that you're measuring?
I believe so.
Okay, interleukin 6, interleukin 2, all the interleukins. So all of those basically are just different weird chemical names of those chemical molecules that are simply inflammatory. So basically, we don't want them at high levels in our blood. And this is what happens in a state of low testosterone situation. You actually have more inflammation going on. And whenever you have more inflammation going on, then you're definitely propagating the whole cardiovascular disease pathway.
Right. And we know inflammation contributes to a lot of disease processes, including heart disease.
Mm-hmm.
And that's probably overlooked a lot in the whole debate between, well, it's LDL that causes heart disease, it's cholesterol. Well, I think you need to have this inflammation and this damage in the first place. And then, yes, you add on high lipid particles. Sure, yeah, heart disease can happen.
Right? It's the damage to your LDL particles, not their overall number, right? It's when they get damaged or oxidized from inflammation. And inflammation can happen from so many reasons. For if you're eating a lot of sugar, seed oils, not working out, smoking, drinking alcohol, being exposed to environmental toxins and endocrine disruptors in your personal care products. I mean, so many things you can lead to inflammation, you know, so
And
that's the real, yeah.
This probably, if you look at the data, and we come across this all the time when arguing with our colleagues. So this guy that we just looked at here, he would have been on the news like, oh, look, carnivore diet causes a stroke, causes a heart attack. But was it the carnivore diet, or was it the other things? Was it 140 grams of sugar a day?
Exactly.
And this is sort of epidemiological data that we are approached with every day.
You can't ever say that a carnivore diet is going to cause heart attacks, given that we ate a carnivore diet for 99.99% of our existence as a species here on Earth, and we had no heart disease. I mean, heart disease was so rare, it wasn't even in the medical textbooks up until the early 1900s. So if there was never a correlation between eating meat and heart disease for millions of years, you can't now try to establish causation, right?
Right. And low testosterone levels are associated with a lot of chronic medical conditions, the metabolic syndrome, the diabetes, the dyslipidemia, which means bad lipid panels, high blood pressure, renal failure, malignancy, and cardiovascular events. So testosterone is more than something that can make you feel happier and improve your muscle mass.
Yep.
Here's more on testosterone deficiency and CAD. Let's look at
coronary artery disease. So just basically showing us more, right, how the low testosterone is going to be associated with higher chance of getting coronary artery disease.
Yeah. So let's look at another case study here. So we have two different type of brothers here. They're similar to me and my brother. They're about the same age, but one used testosterone to enhance physique, the other didn't. So we can see the brother on the left here who never used testosterone levels. He had a fantastic level of total of 1,009, a free of 17.7. He had a pretty good physique too. He's muscular, he's fantastic. Now here's the brother on the other hand. He went on a cycle or two of testosterone at age, pretty young, 22. He never did any post-cycle therapy, right? You can do post-cycle therapy to maybe restart your testosterone levels. He never did that.
What is that? I've never heard that before. Can you spell it out?
Post-cycle therapy?
Oh, post-cycle therapy. Can you elaborate just a little bit on that?
It's just pretty routine in the bodybuilder community. They'll use things like human chorionic gonadotropin. This is HCG. It's injectable. They'll use clomiphene. Maybe they'll use an anastrozole. So this is things that they use to restart their own secretion of testosterone after shutting their own production down with exogenous testosterone usage.
Interesting. And so that's what you would recommend for people coming off of steroids to do then, right?
Well, all bodybuilders know this, right?
And what about if they're taking testosterone bioidentical hormone replacement? I guess if you're taking bioidenticals for a good reason, there's no reason to stop, right? And there's no reason to do the post-cycle.
No. So if you use it as a young athlete, you can shut yourself down, maybe permanently. So we don't start it in young athletes typically, unless there's something really bad going on. Maybe they had some traumatic brain injury that shut off their testosterone production. Maybe they were in the hospital for a time, it shut them down. Maybe they had a burn, so burns can do this too. Maybe this would be some reasons to start testosterone therapy in a younger individual. Older individual, not an issue. Maybe you've had some children, you have low testosterone, trying to prevent some of the risks that we talked about earlier, the cardiovascular risks, bone frailty, etc. You want to get on testosterone replacement therapy. This is the best thing you can do for yourself.
Right.
Yeah,
as you age,
you can shut down your natural production, sure, but does it really matter at that age?
No. Right, because it's already shut down due to the aging process. So at least you can slow down the aging process by taking those bioidenticals. And we know that aging is really the root cause of every major reason Americans die, like the top 10 reasons, causes of death. Aging is the major contributor. So it's the root cause for why you're going to eventually develop cancer or heart disease, etc. So if you can slow down aging, you're affecting all of these pathways. And you're lowering your risk for really all of those diseases that end up killing us eventually.
Yeah. So here's one other maybe exceptional one. Like I've tested a lot of guys, and like it's so extraordinary the low levels that I see, but I know they're not normal. I don't think it's normal to have low testosterone for young guys. But this is a guy who's also decently exceptional with a free testosterone of 19. I don't always see that. He's not even optimized. You know, he dips, he drinks alcohol, he has a bit of extra fat on his belly. He's got low B12, he's got low vitamin D. His T3 is really good, exceptional at 3.7. I don't always see that either. But he has decent muscle mass. He lifts weights, so he's not even trying that hard, and he still has high free testosterone. But I expect if he continues on this path of dipping and beers and so forth.
This is gonna sound stupid, but what does dipping mean?
Oh, it's chewing tobacco.
Oh, wow. I had no idea. Okay.
Yeah, it's common among baseball players.
Right. But like old baseball players, do people still do it to this day?
No, what they do is on the field, it's boring baseball. What you do is you dip and you chew all the time because you're standing out there.
Because it's just so boring.
It's so boring. So they dip and
That's
chew all the time.
hilarious. Okay.
Yeah. But yeah, I think this guy will decrease his testosterone over time if he continues like this.
Yeah, he's very young still. I mean, at 30,
Yeah, he's had 2 kids as well.
Mm.
There's some indication that maybe having children will suppress your testosterone.
It's true. It's true. Yeah, it lowers your testosterone.
So here's ours again. We already covered that. So
How old is your brother? That picture was you with your brother, right?
Yeah,
And
that's my brother.
how old is your brother?
Oh, he's like 2, 3 years younger than me, so he's probably 27 at this time.
That's fantastic. And you're both ripped. Would you say, what about your parents? Are your parents also in good shape, or have they struggled with overweight or obesity?
No, no, my parents have always been thin, and they've always been really good about diet and using diet to control disease. And they've done every diet in the book. I actually have a video I released with my mom talking about all she's been doing for longevity. I mean, she's been into this way before I even got into it. So she's done everything under the sun. Every supplement, resveratrol, NAD, growth hormone, you name it, she's done it. So you watch that video, it's about 45 minutes long.
It's on your YouTube channel?
Yeah, I released it this week.
Oh, fantastic. Yeah, I'll link your channel and everything in the description box below so people can find it easily. That's so cool. Yeah, I remember you told me about your parents being very into all this stuff, and that's how you got into this field and you got this interest.
Yeah, I mean, they raised us very holistically. They never gave us any antibiotics. We never got any vaccines.
Wow.
You know, we never got brought to the doctor. It was always nutrition. That's it.
That's amazing.
Amazing.
Yeah. Okay.
So that may be a reason why we are outliers here and our hormones are decently preserved. Now, my brother's estrogen is a little bit high. I think he's slacked off a little bit on the diet, a little bit more alcohol use. And right now, when he got this test done, he was sitting with a little bit more abdominal fat. So that's maybe why the estradiol is a little bit high, but still his testosterone is extraordinary. So he just needs to maybe take some supplements to prevent some of that aromatization.
Right, right. I think the diet also is such a huge part. And if he's using some personal care products like endocrine disruptors, that
Yeah, he loves sunscreen. I can't talk him out of it.
yeah, there you go.
Yeah. So overall mortality and testosterone replacement therapy, less death is pretty cool, right? You decrease abdominal fat. So we know that visceral fat is an independent marker of all-cause mortality. It's pretty cool. So you got to watch your visceral fat. Make sure that doesn't happen.
Love it.
And fake news will always fear-monger the risks of TRT. I see this all the time, right? They say it causes heart disease, causes cancer. It's not true. It's all nonsense. Just look at the data. The overall preponderance of data is that higher testosterone is associated with less all-cause mortality and all-cause diseases.
Could it be also that older generations of TRT maybe had different effects? Kind of like with
Yeah,
women, female hormone replacement therapy, like the older ones were probably increasing risk of breast cancer, but the newer bioidenticals don't carry that risk profile.
testosterone hasn't been around for a long time. I think it was first identified in 1888 when a physician used a testicular extract from some animal and was injecting it in himself. And he claimed it was like the cure for aging. So you can use bioidenticals. The synthetic stuff, I wouldn't get into that so much. A lot of kids nowadays, they're getting on these synthetic testosterone. You can get them over the counter in some supplement stores. Wouldn't do that, right?
Really?
Oh
Synthetic,
yeah.
what are you mean, you're talking about steroids?
Yeah, we're talking about non-bioidentical testosterones or synthetic sort of testosterones, and they're using a lot of these like oxandrolone and stuff like that.
Okay, so aren't those illegal?
This is a gray area. I mean, they buy it online or they get it at certain supplement stores.
Gotcha. Okay. I will ask you in a second about like what form that you prefer of testosterone, but I do want you to, finish the slides.
Oh yeah, sure. We can talk about that. We're going to get into some of the cases of replacement soon.
Cool.
Let's talk a bit about serum testosterone versus salivary testosterone and maybe the differences in between. So here's my extended hormone panel. This is the blood, estradiol 27, dihydrotestosterone 57. So
Mm,
DHEA 215 in the blood, IGF-1 for 143. It's actually kind of low, so I have been actually using some CJC ipamorelin on occasion to help myself recover from certain strenuous
so
events.
so you want your IGF to be higher.
I do, yeah.
Okay, interesting. And is that in order to like put on muscle or is it for recovery?
I use it for recovery,
Hmm,
right? So when I measure IGF-1 in young teens, so 15 to 16, they're in like the 300s, 400s, 500s even.
really?
And yeah, so I go out and I compete against these kids playing tennis, and my body doesn't always recover as quickly as theirs. So if I'm
Could
trying
it
to keep up with teens,
Could it be because I guess we should tell our audience that you're a competitive tennis player and that's your sport that you compete in tournaments and stuff. And so
yeah.
could it be that the teams that you're competing against they're a carbohydrate loading group? Because I think it's very rare to find any like athletes that aren't loading up on the carbs, right?
Yeah, I think they're all eating, sandwiches and stuff like that. I mean, I do use carbs. I use white rice during these tournaments.
Right, just targeted. It's kind of like a steroid, right? When you use the carbs, it's like you're taking a natural steroid in a way to artificially increase your performance. But then,
Yes.
are you having rice when you're not competing?
I haven't had rice recently. I've actually been on a bit of a sourdough bread kick, and it's inflamed my tennis elbow. So I should probably go back to white rice if I want carbs.
Right, right. Yeah, yeah. All carbohydrates. I mean, the wheat is gonna have
The
the
wheat does it for my tennis elbow. Like I gotta cut it out. I feel it. I've been
yeah.
injecting myself with BPC 157 into the lateral epicondyle area to help it
Yeah.
repair. It
Yeah,
was
if your
dread.
body's reacting to the gluten, and we don't even know how many additional, I mean, you've got phytates, tannins. I mean, there's so many things in plants. And even rice, even grains that are gluten free, they all the grains contain prolamines, which is the parent family of things like gluten. Gluten just somehow is far more popular and people know about it, but you've got prolamines in all the grains. And so this is why a lot of people have celiac or gluten sensitivity. They'll go gluten free, but they'll still have the same symptoms and they will not, their gut will not replenish its the health of its microvilli. So you'll still see stunted microvilli. So their gut health is still messed up because they're still consuming the grains. They're still getting exposed to those prolamines. Some health experts would even say that those prolamines might even be worse off for you than gluten. It just happens that gluten is more well known.
Uh-huh.
Yeah.
Here's a comparison of my serum testosterone, that means blood testosterone versus salivary testosterone. This is a company I use called Access Laboratory. So I was trying to compare the two, trying to figure out. So apparently salivary testosterone is the free testosterone, but the reference range is completely different than the free testosterone you see in the serum, at least from LabCorp. So my salivary testosterone was 97, which is very good. And then at the same time, my free testosterone in the blood was 20. I would recommend, if you're doing blood work, just do one lab, because every lab has their own reference ranges. It gets kind of confusing.
Right. So salivary, you said that salivary testosterone is like a marker of free testosterone?
Correct.
Interesting. Okay.
If you ask some of the experts, like Dr. Pamela Smith, I mean, I've asked her at some of these anti-aging conferences, but she's sponsored by Access Lab, and she says the only way you got to measure it is with salivary. Okay, whatever. And then I asked Dr. Mitch again, and I was like, hey, which ones, what do you think? And he's like, serum is fine. Just measure the blood. It's fine.
Huh.
Just pick one and follow it.
Okay.
But I was doing a couple just to see if I could figure out the difference. So this is a guy, he's in his 60s. Here's his blood testosterone. It's pretty low. And then his total, his serum, his salivary testosterone is also low. So there's kind of matching up already. So we saw mine, it followed. And then we see here, it sort of follows. I think they decently follow each other. And we can see their age-dependent reference range is 40 to 170. So he's definitely low.
Gotcha.
And he's injured. He tears his rotators. So I think there may be some contribution to his low testosterone and his recurrent injuries. The price difference between these two, so you can get a lot of bang for your buck with the salivary hormone test. I do these for my patients. It's not too expensive, and you can get a lot of value out of this. If you try to measure all of these in the blood, it might be a bit more expensive. Like DHT by itself is like $34, $40. So if you really order all these tests, it can get quite expensive in the blood work. So when I order the blood work, I look at basic stuff: total testosterone, free testosterone, LCMS, a progesterone, and a DHEA sulfate, which isn't perfect. If you looked at my records there, my DHEA-S was normal. It was like 200. But then on the salivary, my DHEA, whereas it was low. It was like less than 10. So the DHEA salivary is more of the free metabolites of that. So I've actually been taking DHEA ever since I saw this test.
Gotcha. So what is the LCMS that you mentioned?
It should be the gold standard of measuring hormones. It's a higher end test at these labs.
Oh, okay, so that's the name of the test that you would order, and it gives you the panel of all of the sex hormones.
No, LCMS is just the sort of machine that the blood is run through. So you can get LCMS of any of these is more expensive.
Oh, okay. Gotcha. I get it now. It's like what type of test you're getting. You're running it through a different kind of machine.
Right, different kind of machine.
Gotcha.
Coronary artery disease and myocardial infarction. So again, some of the data here, testosterone prolongs time to exercise-induced ST segment depression. So that's pretty cool.
So that's ST segment depression. It's if you're looking at your EEG electrocardiogram, so it kind of regulates your heartbeat, basically.
Yeah, you don't want an ST depression on a stress test. It's not good.
Yeah.
Okay. Okay, so we have a 36-year-old ex-football athlete. So we know that traumatic brain injuries is possibly causing a lot of suppressed testosterone out there. I see this in my veterans community. A lot of my veterans come to me. They've had TBIs. They have low testosterone. This football player, this is also well known in the literature, that repeated traumatic brain injury can cause a lot of hormonal dysregulation. So this guy, he had also listened to you. He listened to Carnivore MD. He was doing an animal-based diet. He was, I met him first thing. He was eating a bowl of ground beef, really low sugars. He was doing it all correctly. But here was his blood work as a result. Really low testosterone. He's overweight. He's struggling to motivate himself to the gym. And he's getting there, but he's just not seeing the results. It's not fun, right? Insulin's 22, so kind of high fasting insulin. he has a lot of extra fat mass, as we're going to see. He was nice enough to share his video and his picture, and agreed to show to the world his results here.
Yeah, we're not outing our patients. Don't worry. We always take
No,
consent for.
he said he thought it was very important to show to everyone that, you know, you can try animal-based diet to lose weight. You can, but you know, if you have low testosterone, you're going to struggle, and you're going to struggle endlessly and not see the results. So we got him back on a replacement dose of testosterone therapy. We're doing injections twice a week. Very convenient, very easy to do, very affordable. And he's seeing, you can see his trapezius, his massive trapezius muscle coming back. You can see the abdominal muscles starting to creep back up on him.
Yeah.
Right? You can see everything kind of coming together.
That's fantastic.
Right.
Wow. It says, I think there's a typo in your little paragraph. There
yeah.
it says, I think it should have said the one on the right was me 2-3 years ago at 365, and then the one in the middle,
this was
right?
him at the start about a year ago, and then
Yeah,
this is
and then
correct.
exactly, and then the one on the left is me at 330. So yeah,
Yeah,
that's amazing. And is that the guy that you told me about, Nicholas?
Yeah,
That's Nicholas. Nice.
Yeah.
I was gonna ask you about him. Fantastic.
Yeah. So here's some of the data, the effective statin therapy on testosterone levels. So we can see a relationship between treating patients with statins, these cholesterol-lowering agents, and lower testosterone. So there might be some risk there for that.
And that could lead to erectile dysfunction, which, you know, can be very stressful, and, you know, it comes with a whole host of mental health issues.
Yeah.
Yeah.
So we always have to address this elephant in the room. A lot of patients will tell me, well, what doesn't testosterone cause prostate cancer? And the answer is no, it doesn't. And one of the leading authority figures on this subject is Dr. Morgenthaler. He's been doing a lot of this studies. He's been actually treating patients with aggressive prostate cancer with testosterone therapy. No increased risk of death, no increase in metastasis of prostate cancer. You'll hear this all the time from patients who've read CNN and New York Times.
Right, right. Oh, yeah. I feel like a lot of the functional medicine anti-aging treatments that we use that target the root cause is always kind of attacked from the mainstream. And, you know, most of the pharmaceutical companies also, because they're like a completely different paradigm, a completely different way of handling diseases like, let's say, erectile dysfunction. You know, they're not looking at trying to see what is the root cause of the erectile dysfunction. They're looking at, okay, what's the pill that's going to suppress the symptom and just allow that person to have a normal sexual life. And it's just like, that's it. That's the extent of what they're trying to do. What's the pill?
Yeah.
Yeah.
Here's a cool one I found, I think somewhere over in Germany. They're doing some studies looking at less major cardiovascular events under long-term testosterone therapy, 15-year data. Very cool. So we're having increasing support even from our literature on using testosterone to reduce cardiovascular mortality. Now, if you look at any sort of mainstream guideline, how do you reduce cardiovascular mortality? Oh, it's a statin. It's a vegan diet. Okay, but here we're looking at it from a completely different perspective. Long-term testosterone therapy reduces cardiovascular events. That's mind-blowing for anyone practicing conventional medicine, any medical student out there. They're not learning this.
No, because they're not thinking from a root-based approach, understanding that it's aging that increases our risk for heart disease in the first place. And anything we can do to slow down and reverse the aging process, that's what we should be looking at.
Yes. Let's look at this. So we got to address this one. Strict keto crushes testosterone. Wait till you see this one. So we have this guy. He came to me, standard American diet. Okay. Seed oils, carbs, no resistance training. He is diabetic. Okay. He was on metformin. Okay. LPIR score of 81. Not good. No. Very large
particle size. So he's got a lot of those small dense LDL, which is a fraction of LDL, the type of LDL that is correlated with heart disease, but only when it gets damaged.
Yeah. So not good here. We did a salivary hormone panel on him on the SAD diet. Pretty good. 77 of salivary hormone. Hey, that's not bad. Okay, so we don't really need to treat him for testosterone. Okay. So this guy has gone strict keto and is resistance training with the X3 system. He feels great. His testosterone went down to less than 5. And I was like, no, this can't be true. So what I did is I repeated the test.
Okay.
And it was confirmed. He still has very low testosterone, 7. I called up the lab. I spoke to Dr. Again. I was like, what the heck is going on here? This can't be real. He's doing everything right. He's resistance training. He cleaned up his diet. We confirmed it twice. It was correct. However, everything else improved. So his LPIR score went down to 25. So he was here over in the 80s, and now he's fantastic. Okay.
Wow.
His triglycerides are low. Everything improved here. All his scores improved.
His triglyceride is 63, which is phenomenal. For somebody who had his history.
Yeah. Phenomenal. And he feels great. It made no sense. Like his testosterone levels, it made no sense.
Did he lose weight?
Oh yeah, he lost weight.
You know, that's why I feel like sometimes maybe what happens in keto and carnivore, because I've seen this in a lot of people, keto carnivore, they're doing fantastic. Everything is great. Like they would never want to change because they just feel so great for the first time in their lives. But it could be that it's just our tissue sensitivity to the testosterone improves. And so the body doesn't have to maybe pump out as much testosterone. And I have a feeling like, because we see the similar thing with free thyroid hormone and just the thyroid panel. And it's like the metabolism doesn't slow down, even though the thyroid hormones drop on keto and carnivore, but the metabolism stays the same. So that means it's not really a situation of hypothyroidism. It's a situation of maybe improved peripheral tissue sensitivity to those hormones, you know?
Yes. And it's very difficult to measure androgen sensitivity. I haven't figured out a way to test for that. But this guy, on my recommendation, he added back in some carbs to the diet. And his testosterone, it came up. So total testosterone of 600, free of 9.7. Still not fantastic, maybe because of a high sex hormone binding globulin. You can see this sometimes when you do strict animal-based diets, is you get a high sex hormone binding globulin. This is what Carnivore MD figured out as well, which is why he's adding back more fructose to his diet.
Right. That scares me to recommend that, because a lot of people who had gained weight with the carbs, is a lot of it is sugar and carbohydrate addiction. So it's like playing with fire, you know, when they go back to having some carbs and some sugars, and it scares me. And so, which is why I still, you know, to this day, I'll still recommend carnivore. Despite knowing these things, I feel like we need more data, more information to kind of really establish what is really going on here.
Monitor the labs is all I can recommend. Do before and afters, track things.
Yeah. Yeah, no, I agree. Having labs is I think it's great, especially when we see the phenomenal results we get with the triglycerides, with the insulin, you know, with the fasted blood sugars, all those things.
Yeah. Here's a little bit on chronic kidney disease and how testosterone deficiency plays a role in this. And I think it's, especially patients with chronic kidney disease, you need to measure their testosterone levels. You give them back testosterone, they won't be so anemic anymore, right? It stimulates erythropoiesis. So a lot of these kidney disease patients, they're suffering with anemia constantly.
Wow.
And now we have studies here suggesting, hey, give them a little bit of testosterone. It won't kill them, and you'll improve their anemia.
Right.
Make them feel better. They'll have less muscle wasting, improve libido. This is all things good and that CKD patients suffer with. Androgens and diabetes in men. We know that the metabolic syndrome is associated with the low testosterone for the most part. So in conclusion, the data is, I guess, helpful to support testosterone use in diseased populations, but really I can't figure out what is an optimal level from the literature. You have to look at the patient on a case-by-case basis. You have to ask them how they feel. You have to measure their hormones over time to track the fluctuations in this. You have to experiment with diet, supplements. You have to listen to their history. Maybe they do have a real reason for why they have low testosterone, like a TBI, maybe sort of some disease process. Maybe they just low testosterone in general. They've been like that for years. Maybe they've been like that since their teens. They just suffered all their life and they don't know any difference. You put them on testosterone and they suddenly feel fantastic.
Yeah. Okay. Can I ask you a few questions?
Sure.
On that? So the bioidenticals, which one would you say is your preferred form of testosterone replacement therapy?
Testosterone injections twice a week. Simple. It's effective. We know it's therapeutic. The testosterone creams, they can work for some guys, but it really depends on how good blood supply they have to the area that you're applying it to. Some guys, they find it works good putting it onto the testicles. They apply the cream to the testicle, obviously shaved testicle. But then with the cream, you have to make sure you wash your hands, right? You don't touch the cat, that stuff. So injections, very simple. I don't recommend pellet therapy for men. The reason is because you will burn through the pellets of testosterone when you resistance train. And so you need to always do them. You need to do it every couple months, where with a woman, you can get maybe 3 months, 4 months out of it. With a male who's resistance training, you'll burn through the testosterone pellets maybe in about a month. So not worth the pellet for a man.
Interesting. So like the muscular contraction speeds up the release of the hormone from the pellet?
Yes, you burn through the testosterone more.
Wow. Okay. But wouldn't the same thing happen to women? I mean, if they're also resistance training with pellets?
Yeah, but women require much less testosterone. So you have to think the pellets are these like little BBs you inject into their buttock, and it releases the hormone over time.
Yeah.
So they have much less demand for testosterone. So the overall size of the pellet and the amount of pellets you have to shove in there is much less. So a woman has 10% of the testosterone that a male has. So you have to shove a lot more pellets into the man to get them to where they need to go.
Gotcha. Okay. I know my hubby takes testosterone cypionate as a bioidentical. Do you have any thoughts on that?
T-SIP, that's basic. You know, dose it twice a week. So I have some guys do microdosing 3 times a week. That's sometimes more or less painless. You can use an insulin needle and you do microdoses of this rather than doing like a large volume injection twice a week. So some guys maybe even do it every other day. I've heard some YouTubers, they do it every day with an insulin like microdose. So you play around with it. You see what you can do, what you have time for, what you prefer.
Gotcha. And we talked about the dangers, right? There are really no dangers for testosterone replacement therapy. And I think the only caveat that I would say here is that sometimes if you're just taking it to not address the root cause of low testosterone, maybe then that would become a problem. I think first, like try to go through a program where you're looking at your personal care products, you're looking at your diet. Don't just leave everything in your lifestyle the same way and then just take the injection, because it's like you're losing the ability now to detect if your lifestyle changes are improving your hormonal profile. Would you agree with that?
The opposite of that is if you have low testosterone, you have no motivation to make any of those lifestyle changes. So sometimes you just have to treat the guy. You have to get them out of the depression. You have to give them the motivation. Yeah, you'll feel the results of going to the gym. Who wants to go to the gym and be in pain the next day and not recover because you have a testosterone total of 200? Okay. Give them testosterone and suddenly they enjoy going to the gym and now their metabolic syndrome goes away because they're training every day.
Gotcha. Okay. And let's talk a little bit about, so growth hormone supplementation is illegal, right? But you can do peptides that stimulate your own body's secretion of growth hormones.
Well, there is a diagnostic criteria for growth hormone use, and it's called adult growth hormone deficiency syndrome. And some patients have this, specifically the morbidly obese. They will have suppressed growth hormone or IGF-1. So you can make the case to treat with growth hormone, but it's exorbitantly expensive, right? And no insurance company will cover adult growth hormone deficiency. They might cover things, Turner syndrome, stuff like that. You know, I have a Turner syndrome girl on my panel, and insurance company will pay for that.
Can
However,
you describe what Turner syndrome exactly is?
It's a genetic abnormality. Yeah, they're born with it.
Where
There's
you
nothing they
can't
can
make
do.
growth hormone.
Well, they can make some growth hormone, they just don't have the sensitivity to it. And so
Ah,
if
okay.
they want to grow properly, you need to give them exogenous growth hormone every day.
Wow. So Turner
They'll have
syndrome,
short stature. Even if you do all your best, they'll still have short stature.
they have a missing or incomplete sex chromosome. So it's basically a female that is born with only one X chromosome. So I guess the symptoms can be wide ranging then.
Yep.
Yeah, gotcha. Okay. Okay.
But yeah, the peptides are way more affordable to use. Now, the peptides were initially studied in patients like the Turner syndrome.
Mm-hmm.
However, they fell out of favor because they're not as potent. So if you really want someone with to grow with a growth hormone deficiency, you need to give them real growth hormone like omnitropin or ditropin. The growth hormone peptides are not as potent, obviously.
Gotcha. Okay. So you can prescribe for adult growth hormone deficiency. It's just that it's going to be, I think, like $1,000 a month, right?
Yeah, at least.
Yeah, it's pretty expensive. Um, but there are things if somebody cannot afford those things, there you can literally just do fasting. I think like
Yeah.
what 2 days of fasting increases growth hormone secretion naturally in your body by like 2,000%, something
Yeah,
like that.
it's amazing. It
So
does.
yeah, that was an amazing study when it came out. And then we talked about the post-cycle therapy, but I guess if you're doing it for anti-aging, there's really no reason to do the post-cycle therapy because if you're aging, diet and lifestyle factors alone are not going to be able to stop the aging process. And the only thing that can slow down the aging process moving forward now is having to replenish your hormones that your body can no longer create.
Yeah.
Just like women go through menopause, men go through andropause, right?
They do, but it's just not as rapid. So it's kind of like a slow decline over time, where women is like that. They got no
Overnight.
estrogen and progesterone. They start getting hot flashes. Men don't really experience hot flashes like that. But they just kind of see a slow
Right.
decline.
I'm very excited for the next lecture we're going to do, which is optimizing female hormone replacement therapy or optimizing female hormone therapy. Hormones, that's it, end of
Yes.
sentence. So I'm excited
Yes.
to do that. I'll also, next time, we'll talk a little bit as well. We'll dedicate like an extra also 10 minutes to talk about milk and, unpasteurized versus pasteurized and all that stuff, because I know you have a wealth of data to share with us on that topic. Did you want to add anything at the end?
No, we are accepting new patients here at Iron Direct Primary Care. I brought on a new physician on board. He's licensed in 4 states, so we're going to be able to help a lot more people.
What are those
So you
states?
can find, I think he's licensed in South Carolina, Tennessee. It's on my website, I forget.
Okay.
And we have a new office in Indialantic. It's going to be fantastic. I just bought the Morozco Cold Forge. So we're going to be doing cold therapy, cryotherapy. We're going to get a sauna and we're going to get a hyperbaric oxygen chamber. And the Dr. Matthew Tinney, he's a huge proponent of using IV ozone to treat all sorts of chronic diseases, chronic EBV, long haul COVID-19, all sorts of things. We're doing IV nutrition therapy. So it's really going to be like the go-to spot to reverse difficult diseases.
Where is it that you're setting all this up?
It's in Indialantic, Florida.
Atlantic?
Indialantic, yeah, it's on the East Coast here in
Never
Brevard County.
heard of it. Wow. Okay.
I know, yeah, it's a really nice spot, but we do a lot of telemedicine, so we can help patients in a lot of different places.
Fantastic. Well, I'm going to make sure that I link all of your information in the description box below, your website, YouTube channel, your Instagram. I know the algorithms don't like you too much talking about the V, you know what I mean, and all the stuff. We got censored heavily, but you're very courageous and you don't care. You'll say it like it is, and so this is why it's so important. Like when we collaborate and my audience gets to know you, hopefully, more and more people can find you that way. I love all the work that you do, so thank you so much. I appreciate your time and sharing all of this data with us, and I am looking forward for round 2 with the female hormone optimization one that we're going to do. I think around in a month it'll come out.
Yeah,
So
can't wait.
Awesome. Thank you. Thank you for everybody for sticking with us till the end. If you enjoyed this video, make sure you give it a thumbs up, subscribe, and hit that little notification bell icon so YouTube alerts you every time I post a new video. Thank you all, and I will see you in the next one. Let me stop the bye.
Bye.
Wait a second. Let me stop the recording first.